Hey everybody. So thank you guys so much for coming. My name is Lauren Tallman. I'm a neurologist coming from Portland, Oregon. So I work at OHSU and I direct our Huntington Center there. I actually gave this talk last year in Spokane, and I think they wanted to invite me back to give it again just because this is an incredibly important topic, and it's something that I've become more and more passionate about talking about things early. So props to you guys for being here, and just as she mentioned, we would love feedback on whether this is helpful. So we'll take a whirlwind tour through a few different topics today. We'll start by just defining what we mean by advanced Huntington's as well as end-stage Huntington's. And then we'll talk a lot about what we mean by advanced care planning. What sorts of decisions do we need to think about early? And maybe most importantly, how do we start those really difficult conversations? I want to start by saying this is not an easy topic. It's not an easy topic to talk about, to think about. So I want to just sort of respect that and say that if you kind of feel emotions coming on, that's okay. You can either sit with those emotions or you can step away. You're not going to offend anybody. I also want to say that everybody's journey with HD and the decisions that they make are really personal. So whatever decision you make now or in the future, there's no right or wrong answer if it's your decision. So again, we're all unique here. So as I said, I want to start just by defining what we in the field mean when we talk about late stage or advanced stage Huntington's disease. Some might be familiar with this scale called the Total Functional Capacity Scale. And that really gives us as clinicians kind of a bird's eye view of where we are in a person's journey with Huntington's disease. And really what this scale is looking at is how independent a person is with their everyday or more complex activities. And when we talk about advanced stages of Huntington's, we're really talking about people who have gotten to the point where they're dependent on others for their activities of daily living. Not only are they not working, but they need help with self-care. They're maybe moving out of the home because of those increased care needs. The other thing to recognize is I've had a lot of caregivers, care partners kind of get to the point where their loved one is in that advanced stage and they feel like, okay, we've sort of gotten to that point where maybe this is going to move quickly and my person will pass peacefully soon. But it's important to know that some of these advanced stages can last a long time, okay? So you kind of feel like you got to the end of the race and now you're in this really tough waiting game. So it can last years and sometimes up to a decade. And that's why, again, talking about these things early is really important. What does advanced HD look like? Well, this is certainly not an all-encompassing list, but I think it's a starting point to kind of get a sense of what our loved ones might look like in this stage. So from a motor perspective, that sort of characteristic chorea, involuntary movements that we might see earlier on in the disease often fade away. So a person might become much stiffer, much slower, and might develop what's called dystonia, kind of changes in posture of our arms or legs. Speech and swallowing certainly can be much more impaired, and that kind of goes hand in hand with the cognition, where individuals have difficulty expressing themselves. So they can't really tell us what their wishes are, what their needs are. From a behavioral standpoint, behavior doesn't always progress in the same way that some of the other categories of symptoms occur in Huntington's disease. Behavioral changes often kind of ebb and flow. For some people, they might toward the end have a buildup of difficult behaviors, and then for others, those sort of fade away. So again, very different in different individuals. But as I mentioned, universally in advanced and end stages of the disease, we're needing help with everything day to day. I'm not going to go into this in detail. HDSA has really awesome publications out there that give you all of these tables to reference, but just to say that they do have a table similar to that total functional capacity I mentioned for general Huntington's. They have one that's dedicated for advanced stages too. So we talked a little bit about advancing HD. What do we mean by end stage HD? And usually when we're using that terminology, end stage, we're talking about nearing the end of our life, nearing the point when a person will pass away. So this is, again, generally speaking, a person is largely in bed at this point. They're not able to express themselves. Now, again, we as clinicians always try to recognize that there's someone in there, okay? So even though they're not able to express themselves with words, they may express themselves in other ways, and we give them that dignity when we're talking around them and talking to them. Another thing we can see in this stage is because of that challenge with swallowing, people may start to have kind of recurrence of aspiration. Things are just going down the wrong tube, and that can lead to pneumonias, hospitalizations. In addition, because of that difficulty with swallowing, even when caregivers and care partners are doing their best that they can, a person may not be able to keep up with their nutrition, and we can certainly see weight loss as part of this. I had mentioned how behavior can vary, but there can, for some individuals, be what we call kind of terminal agitation, where in the really nearing death, nearing the end of their life, again, likely because they can't express themselves and they have all of these changes going on physically, we can see a bit of agitation and aggression in this stage, and that can be really hard for family members and caregivers and care partners to witness. Now, the weight loss that I had described is probably multifactorial. Certainly, we're not getting as much in orally the way that we typically would, just because of swallowing impairments, maybe decreased appetite. We also know that in Huntington's disease in general, with or without those extra movements, there seems to be this higher metabolic rate. So weight loss is pretty universal and can be much more rapid in these later stages of the disease. Because of that tendency or risk toward having aspiration, we might see changes in a person's respiratory patterns as well. It's also quite common that we just see a lot more inactivity. Not only does a person sleep through the night, but they might be sleeping through the day. So they just don't have as many of those good moments of being awake and engaging with their surroundings. They will have difficulty controlling their bowel and their bladder. And again, that sort of lends itself to needing that additional care. Pain can be a component to end stages of HD, and that again could be from a combination of things, but it's also a reason that we might see that sort of nonverbal or verbal agitation where a person may be trying to express that they're having pain, but it's hard for them to do so. And pain could be, again, from a variety of reasons. If we're sort of in one position for longer periods, that can put some pressure on our muscles and our joints, and that can certainly be uncomfortable. Even just basic needs like I need to go to the bathroom, constipated, or I'm retaining urine, or I'm hungry, that could lead itself to pain as well as sort of those behavioral changes. I do have people ask me what causes death in HD. So these are sort of the most widely recognized reasons that a person might pass away. Again, I think that top one being the most important to consider, which is recurrent infections. Okay, we can also see, particularly if a person chooses not to have a feeding tube, which we will certainly talk about later, not being able to keep up with nutrition could be a reason as well. Less likely, though certainly with transferring individuals, if they were to take a fall and have a serious injury, that could also lead itself to a more rapid passing. So again, I know all of that was not easy to hear and think about, but I think it is important to sort of frame the rest of the discussion in what we see in those later stages, and it helps you to sort of think about what you want in that setting. So this idea of planning ahead is not unique to individuals with HD. We all need to do this with or without HD, and care partners of those with HD need to make these decisions too. So again, it's great to sort of have you here thinking about this. Everybody could benefit. A big reason that we encourage talking about these things early in HD is just what I said. A person's not able to express what they want in these end stages. And so what I like to share with families when I'm talking to them in clinic is that When a person is able to express themselves, giving that gift to a family, to a healthcare team, is immeasurable. So being able to say, when I get to this point, this is what I want or don't want, that empowers family members and healthcare partners to know that they are carrying out those wishes of what their patient and their partner would want. So in a disease and a disorder that makes it so people tend to lose control, talking about these things and laying out our wishes early helps you regain some of that control. As I mentioned before, these decisions are incredibly personal, so they might be based on how old you are, where you are in your life, what you envision for the future, but also we've talked about how HD is a family disorder, so seeing your family members go through the same process might inform your own decisions. So what's an ideal scenario? This is sort of what I envision as an ideal scenario for my patients, and that is having a really dignified end to their life, having them feel that they're at home, whether they're in the home structure that they're used to for years or whether they're in a facility that we've been able to make feel like home. Ways that we can do that are certainly to, again, know what a person's wishes are and honor them. Try as much as we can to establish a routine that's personalized for that individual. Have a set of care partners and caregivers who know that person with Huntington's and know what they enjoy or don't enjoy. And then certainly a person with HD has a family unit around them, so making sure they feel listened and supported, and we're sort of revisiting all of these things as things change. So how do we plan ahead? What is that process? We have fancy terms for everything in medicine. So the way that we describe this is something called advanced care planning. And that's just a way of saying planning ahead and making it official. So this is, again, establishing what our wishes are early before the time comes that a person's not able to speak for themselves. Part of that certainly can be end-of-life decision-making, but even prior to those end stages, there are a lot of important decisions that we'll cover. The other thing to recognize is that this is not just a box you can check, okay? So everything evolves in HD, and so revisiting these same conversations, whether it's annually or when new symptoms arise or when we're approaching a new stage of the disease, make it a process and make it a routine. I think that can also help take some of the stigma away from having these discussions. There's a lot of support for doing advanced care planning. Certainly, as I said, it helps us to adhere to a person's goals, and through that, it improves their quality of life. Because of that, we've actually seen that when we can carry out a person's wishes, it prolongs survival. So it's a pretty interesting phenomenon. The other thing I'll say is that we in healthcare recognize that we're pretty crummy at getting people into hospice early so that we can take advantage of those services. And we'll talk a little bit more about hospice in a bit. But when we have these sorts of discussions, again, it takes that stigma off the table, allows us to get us the services that we need early so that we can take full advantage. So broadly speaking, what do we cover when we talk about advanced care planning? So we'll break these things down individually. Not only do we talk about who we want to speak for us when we can't speak for ourselves, we might talk about where we want to spend our final days. What is that going to look like in terms of our environment? We certainly want to talk about what or which interventions we want, but maybe more importantly, those that we don't want, and we want to make sure we express that. And then lastly, we'll talk a little bit about how we start these conversations and how we make these plans. Okay, so starting with who, really the way that we designate a person is through something called power of attorney, healthcare power of attorney. That's the most common term that we'll use, but you can see that there's a long list here that are sort of interchangeable. Really what we're getting at is trying to designate a person that you trust to carry on your wishes and speak for yourself when you can't do that. Now, this may or may not be your family, okay? That's not trying to be humorous, but sometimes it's people outside of our family that we feel closest to, that we feel will really have our back at the end of the day. You want to find somebody that, even if there's maybe some disagreement on how things should be handled, you want someone who is going to carry out your wishes and will fight for those. It's important that it's not your healthcare team, though I will make the note that we want to know who your person is. We want to know what your decisions are, because it is a collaborative team effort to make sure those wishes are carried out. And then there certainly are some state requirements that I am not as well versed in. The where part of it. So almost universally people say, I want to stay home. I want to stay home till the very end, because it's home. That's where all of us would like to be as long as we can. But I do think recognizing that it is very difficult for a person with HD in advanced and end stages to remain at home. So recognizing that that is part of the planning ahead process, which is to recognize we may need to find a place for our loved one. In an ideal setting, again, having the person with HD be part of that process, maybe looking at facilities when they're still able to participate in that decision making, can make family members feel like they're at peace with that decision. It can be really difficult. I'm not simplifying this slide at all, especially for individuals who maybe do have some behavioral changes in their advanced stages. Finding facilities who are comfortable managing that can be really hard. I know we've had some great sessions at convention going over this, but sometimes finding those that are well-versed in memory care, for maybe the younger individuals, finding those that have experience with other disorders that aren't HD but have some overlap, like traumatic brain injury or other psychiatric disorders. By far and away, I rely a lot on my social worker. So whether you have someone at your center, whether you have a center you can access, or getting through the HDSA resources, that can be really helpful. HD families are an incredible resource. So being at convention and talking about how you navigated that decision, how you found an appropriate place for your loved one, share that with others. Again, there was a session on this, so I'm not going to spend too much time, but I do think that planning ahead also applies to how you're going to finance these types of changes. So even at the very beginning, before testing, we've talked about how it can be important to get some of these insurance coverages in place. So again, won't cover that in detail. Social workers and the folks that are well-versed in this are a great resource. I want to spend most of my time on this what piece, because I am a clinician, so these are the discussions I really focus on. But when we talk about interventions, I'll highlight a few really important ones and sort of hammer out some misunderstandings for each of these. So the first I want to talk about is artificial nutrition. And again, in layman's terms, that's a feeding tube. We use different terms, G-tube, PEG tube. At the end of the day, they're the same thing. It's basically a tube that's placed through the skin directly into the stomach to deliver nutrition, hydration, medications. This is done in an outpatient setting, so not a very invasive procedure, but in our loved ones with HD, it's important to know that there is this risk that they get pulled out, they get clogged. If there's a lot of extra movements, that can dislodge the tubing. So there may be a bit of back and forth with needing to manage this. Also recognize that even if a person's requiring a feeding tube to get some extra nutrition, it doesn't mean they still can't take some food by mouth for pleasure. So those aren't mutually exclusive. A person may just be more reliant on a feeding tube to get the bulk of those things. Reasons that we might start discussing feeding tubes would be weight loss. And again, there are a lot of factors that can play into that. If a person's swallowing is such that they're having a lot of aspiration events. Times when it would not be appropriate, and again, the reason that we talk about this early are in the later stages of the disease. It's a natural occurrence that a person will stop taking food or stop taking hydration. That drive to drink and eat just sort of shuts down. And one could argue that at that point, that's not an appropriate time to be placing a feeding tube, because in a way, that is that person's body telling us that it's the end, okay? And so in a way, you'd be prolonging suffering. Reasons you would potentially consider a feeding tube, at least when I'm, having these discussions, you really want to put it in the context of the other parts of a person's quality of life. So if they otherwise are interacting in a way that they have designated as meaningful, that is a good quality of life, and they want to preserve that time, that might be a reasonable time. But it's not appropriate to use it just to prolong life without quality and dignity. Important other considerations are the fact that feeding tubes do not prevent aspiration. So all of our tubing is connected in some ways. So the esophagus can connect to the trachea through the mouth. So it can go up and then back down, kind of a reflux type of mechanism. So that means that we can still see lung infections even when there's a feeding tube, and particularly when folks with HD are bedbound and they're flat most of the day, that could increase that risk of aspiration. I highlighted a study here just because I think it's really interesting. We don't often have these sort of larger numbers of individuals with HD in long-term care, but this one looked at a proportion of individuals who did pursue feeding tube, and what they found was certainly it extended life for these individuals, but it didn't change their risk of pneumonia, their risk of other types of complications from their advanced disease, and there wasn't, interestingly, a change in their weight. So we may prolong life, but there could be a lot of other factors that aren't improved by a feeding tube. As I said before, if a person's a little bit earlier on in their disease, feeding tubes could also have implications on their ability to interact socially, could change just sort of the nature of how they get their nutrition and the way that they take pleasure out of eating. So a lot of different factors to consider. I'm not trying to push you one way or another, but again, framing all of these decisions in what makes a good quality of life for that person, and do we want to prolong it at a certain point. The next intervention that I wanted to talk about is resuscitation, and we will often use this term code status to indicate what a person's wishes are in terms of resuscitation. I think that the media often portrays resuscitation episodes as far less traumatic than what a person who has visualized these knows them to be. Recognize that when we're talking about resuscitation, we are talking about bringing a person back. So their heart has stopped, they have passed, and we are doing an intervention to bring them back, okay? So you're basically deciding, do we let this person pass peacefully? Do we do all interventions to try to get that heart pumping again? So not only is that things like compressions, but as part of this code process, a person will likely have shocks to their heart to try to stimulate it to pump again. They will likely require IV medications. And then an important point that'll become important on the next slide too is that they will likely need a breathing tube. It can be really hard to separate having our heart stop and needing to do the necessary activities to bring it back and the breathing tube. Those often go hand in hand. Usually a person will require high levels of care after they have an event where their heart stops. And particularly if this happens outside of the hospital, a person may not be the same after, even if they are able to get the heart beating again. And so we're thinking about individuals with Huntington's disease who then have their heart stop and could have other neurologic complications from that. I talked about the breathing tube a little bit, but this often is required after a cardiac arrest. There might be other times like a severe infection, aspiration pneumonia, which we've talked about. Again, saying that we want chest compressions, we want resuscitation, but we don't want a breathing tube is a bit counterintuitive. You sort of need to have both if you're feeling like you want those aggressive measures. Also recognize that when the medical team is performing these procedures, they're not going to know the outcome until they do everything. Okay, so saying, I only want this if it's going to be a good outcome. I want to know that my loved one will recover. We can't know that, and so you have to sort of go in framing these decisions without having all of that information. And that's why that bigger picture of where we are in our disease, what our quality of life looks like, is really, really important. Also recognize that putting a tube in, while it can be reversible, that can be a really emotionally and traumatic thing to go through for a family. So in some ways, not doing these things initially can feel far less traumatic than having to take those out and withdraw care. Another consideration, again, just sort of predicting conversations that could come up in advanced or end stages of the disease, or certainly infections, and how high of a level of care we want to push in terms of aggressive measures to manage these things. So deciding at what point do we say we don't want to keep going back and forth to the hospital. We don't want to keep pushing IV antibiotics or admitting to the hospital or ICU. We want to, again, step back. And I think that's a really nice segue into the next portion of this, which is to really highlight the benefits of palliative care and hospice care when we talk about advanced stages of disease. One could argue that we in HD care provide palliative care from day one, okay? Right now, we don't have a cure. Hopefully in the future we will, but right now our focus is making each day as good as it can be, as full of quality of life as it can be, and managing symptoms. And that, in essence, is palliative care, improving quality of life and relieving suffering. So from day one of getting a diagnosis, that's what we're doing. Hospice care is just a little portion of palliative care, so it's just focused on how we improve quality of life at the end of a person's life. So none of us can really predict, even when we are in end stages, when the end will come. But hospice can help provide resources and support to make as many days as we have left the best that they can be. In the past, there was this concept that we wait to get hospice on board until the very last minute. And I think, again, we in HD Care have really tried to shift things a bit earlier, recognizing that palliative care starts from the beginning, and trying to get hospice care on board the moment that we feel a person would qualify and would benefit. You can also see on that bottom part that hospice support and hospice care continues after our loved one passes away. They provide bereavement care and support to families, so it's ongoing support even after a person passes. So generally speaking, hospice care is shifting again from wanting to prolong life to wanting to improve our remaining days. Hospice can be provided in a lot of different venues for those who do stay at home. Hospice can come into the home. They can also provide services in care facilities. And then there are definitely standalone hospice facilities where people can transition. But they have just a long list of supportive resources that they provide. I think there are statistics that most people spend a matter of days on hospice when in essence, a person could get 6 months or more of those resources if we refer early. So even if a person does outlive 6 months, you can renew hospice and you can remain with those services moving forward. Okay, so that was a lot to cover. How do we initially start talking about these various topics? I have been really trying to make an effort as a physician and clinician to sort of step out of my comfort zone and have these conversations early on. Maybe not the first time I meet someone, but as I'm building that relationship in clinic, as sort of a sign of respect to the people that I take care of, because I think, again, it's a mutual thing where we want to make sure that we're carrying out exactly what they want. So medical appointments are a great trigger for these kinds of conversations. Other people find that Christmas or family gatherings or holidays may be another time. I tried that strategy. It didn't go so well with my parents, so you can try that out. But again, having family together, convening, and bringing this up is something that you really care about. But make sure that it is sort of an intimate setting, a comfortable setting. You're not distracted by a lot of other things. You want to really make sure that you're putting your heart and soul into that. And you can certainly frame some of these conversations, not necessarily in do you want chest compressions, but just what are your values? What makes you you? What does define a good quality of life for you? Whether that's, I want to still be able to hold my spouse's hand, or I want to be able to pet my cat, or I want to be able to enjoy the park. It doesn't matter. It's whatever defines you. So some helpful guiding questions, again, are what gives your life meaning? What really drives you and fulfills you? What are some important considerations for your end of life? What do you fear most about dying or that process? What gives you strength, or it makes you feel like you are empowered to face that difficult point? And then faith and spirituality, if that's an important part of your decision making, that's important to express. So there's a lot of great tools out there. I'm just going to highlight a couple. We have a palliative clinic in our movement disorders clinic who really like this tool called the SMILE tool, where you basically get to nominate different areas of your life that give you meaning. And with each of those, you rate them on how important they are so that those can be really the driving factors in the decision making. So what gives you grounding? What gives you importance in your life? What makes your life overall worth living? And really documenting those, as I said. There's also an HD-specific quality of life tool that helps to trigger some of these conversations and is almost a checklist of sorts where you can go through and think about how much you've really processed these various decisions. And you can rate how far along in that process you've gotten. Again, this would be a lot to cover in one conversation, so having it be that process and breaking it down gradually over time is probably the best strategy. A couple other resources online that, again, are ways to trigger that conversation and help you think about how to frame your wishes as you move forward. Try different ones out and see what works for you. Now that you've done all of that legwork to have these conversations, I think the next step is to recognize that you need to write them down. You need to make them official, and there are some ways of doing that. So we do have legal documents called the Advance Directive that really outlines exactly what your wishes are. That might include your inventory of values, things that are valuable to you and meaningful to you in your life. It will also define, as I said, who you want to speak for you when you're not able to do that yourself. And this can be separate from those financial powers of attorney in terms of who's going to manage your money. And then the living will is the portion that specifically will outline what your medical wishes are, of what you want or don't want done at a certain point. Advance directive documentation is different in different states. You do not need a lawyer to complete this. You can obtain this documentation without needing that support. But it is also important, as I said before, that this can evolve. You might fill this out and then a year down the road change your mind, and you might need to refresh that paperwork, and that's okay. The other thing to recognize is that this advance directive is not something that's going to really hold up in an emergency situation. We'll talk about how to portray your wishes to emergency medical services. But it is important, and I often do encourage individuals to bring in their papers so that their healthcare team and partners know what they've outlined formally in their advance directive. This is a bit outdated, but several years ago it did We did have some evidence to show that this was really underutilized. We just did not have a good number of individuals with HD who had gone through this formal documentation of their wishes. So again, hopefully hearing about these things and motivating to make your wishes known will help move that percentage up. I mentioned before that those advanced directives they're great to have, but they're probably just in your file cabinet. If you have something emergent like your heart stops or you have something at home, emergency medical services, regardless of what you've put in your advanced directive, will still do everything. That is their job. And so there are portable medical orders that can be documented as well. We use this term pulse portable life-sustaining treatment, and it tells emergency medical providers, yes, I'm full code, I want you to do chest compressions and bring me back, or do not resuscitate me, I want to pass peacefully. So that top portion of resuscitation, you can outline that. The second portion on most of these forms, and I've included the Oregon Pulse, that's the one I'm most familiar with, but it also has a section where you can outline what level of care you're interested in. Do you want everything? So if an infection arises, do you want to be in the ICU? Do you want a breathing tube? Do you want IV medications? The second part, limited treatment or selective treatment, is those individuals who say, well, if I have something that's very easily taken care of, I'd be okay going to the hospital, but I want to come home. That's still my priority. I don't want those high levels, aggressive measures performed. And then the lower down is comfort measures, and that is the most practical to be in if you are pursuing hospice. And in fact, hospice does typically require that we've transitioned our goals of care to comfort measures. And that's largely saying, I want to stay in place. I want to be at home, or what is now my version of home, regardless of what arises. So if an infection occurs, if some sort of injury occurs, I want to remain in place and have hospice support in providing comfort, pain management, anything that will help soothe that suffering. So comfort measures, particularly if a person has gone back and forth to the hospital a lot of times, I'll sort of try to step back and say, maybe we need to redefine what our goals are here. Usually what we recommend with pulse forms is that they're displayed in a really obvious place. EMS will often look on the refrigerator as a really logical place. So again, you want to make sure that this form matches what you've outlined in your advanced directive and that it's easily accessible. That was a bit of a whirlwind, guys. So again, we talked a lot about what we define as advanced stage and end stage HD. I think it's incredibly important that you have these conversations when a person is still able to discuss their wishes. I will reiterate the fact that when a person with HD is able to express those wishes, it's a really beautiful gift to their family and their healthcare team. We want to make sure that we're living out a person's wishes, and then certainly formalizing those is the last recommendation I would make, both with your advanced directive and those portable orders. I wrapped up much faster than I thought I would, so that gives us a great opportunity for questions, but I truly thank you guys for listening and for being here. Yeah. So the question was, the pulse, does it need to match the advanced directive? I would encourage that. So the advanced directive is a much more detailed document where you've outlined your wishes, and you want to make sure, particularly in the case when a person has decided they don't want interventions like resuscitation, you want to make sure that that pulse reflects that documentation. Because if we don't have that visible, worst case scenario is a person is having interventions that they didn't choose to have. Yeah. Does that make sense? Okay. Yeah. Yeah. Yeah, so she was just mentioning in Missouri specifically, it sounds like it's a purple form that needs to reflect what a person's wishes are. Yeah, again, in Oregon, it's got bright pink around it. I think that's eye-catching for emergency services to come in and see those wishes. Yeah, hey. Yeah, I in terms of, so the question was what the role of the power of attorney is in the pulsed form. So there are times when the power of attorney or medical proxy can complete the pulse for that individual. I believe there's a designated area where you can say designated representative is signing that form. Another reason, I'm just going on a circle here of talking about it early, because you want to make sure that person is reflecting what you had outlined for them before. But yes, that's a great point, Nicole, that you can have somebody else support you in completing that form. Yeah.
As somebody who's had to make those final decisions on behalf of family members in the past.
Yeah. I'm supposed to repeat everything, so I'm just going to reiterate what you said. It sounds like someone in the audience mentioned that she's had firsthand experience with having to make these decisions, and so having it be outlined by her loved one made it just a little bit easier. Yeah, I think you're absolutely right. That I'm certainly not minimizing and saying that this is an easy process, but I do think it does lift a little bit of that weight in a really tough time. Well, I'm certainly free for any other questions if you guys want to chat after, but I appreciate your time. Thank you.